So I'm going to take you through a very important topic, especially for the obstetrician, as well as for our patients. So next slide, please. Okay. So I will start with a question. Would we screen? Would we offer this aneuploid screening? What are we doing in our private practice? So we have known that, we have been taught that traditionally, people above the age of 35 were the ones offered a screening test. But what was the problem with that? They were still recording babies being born with Down syndrome. Why? Because a percentage of those still okay in a younger population. So what does that mean? So it means that you should offer everyone this screening test. Is it clear? Is it clear? Good. Everyone, whether you're 22 years, whether you're 20 years, you're 35, you're 95, you're 65, it doesn't matter. Everyone need to be screened. So if I find a patient of yours not screened for Down syndrome, what are we going to do for him? Anyway, let me move on. So, you see? So you can mark yourself to say, where are you practicing at? Are you still at the quadruple test? Which means you're still in the 1980s, right? Or maybe you're still at the nuchal translucent, because I get to see patients, I ask them, have you been screened for Downs? Yes, they checked something behind the neck. That's the only thing they did. So you're still there in your 1990s, right? Calm down then. If you are still doing the combined test, you are a better obstetrician. And if you are offering this, you are the best. But of course, it comes with a price, this one. So I think Dr. Verga has already highlighted that most of our patients, they book late, right? So they still need, because with this combined test, we are offering it in the first trimester. But how many are you seeing in the first trimester? Maybe, probably, because I presented data 12 weeks ago, just a few come in the first trimester for booking, which means you still need to do something for those who came at about 20 weeks. Now, so I pose the question to say, in this era, where we got a birth test, which is a non-invasive one, and also you got a combined test, which are also offered in the first trimester, is there room of doing our second trimester screening? Of course, the answer is yes, because I have already alluded to you that most of our patients, they book late. So there's still need for us to cater for these late bookers. Now, this is about the non-invasive test, which is now available in Zimbabwe. What is the good news? Of course, it's non-invasive, right? But what about the bad news? It's still very expensive for much of our patients. And also, we are seeing the good news that the prices are quite dropping with time. But of course, even if you do that non-invasive test, there's still some gray areas which you cannot answer, which are gray zones, to say, where is your patient? So I'll move. So now, I'll teach you the methods, the mathematics, and the myth when we do this test. So I'll talk about genetic sonogram. Don't worry, just jargon. I will show you that it's easy. Then I'll come to the biochemistry and our newer test. So for the background, in case for some of us, it might be difficult to interpret. What are we saying when we say we are talking about aneuploidy, right? So aneuploid, basically, you're talking about numbers. You still remember that your body is made up of 46 chromosomes, which are in pairs. So if you get maybe at chromosome 21, for example, you get an extra chromosome there. That's a trisomy, which is a form of aneuploidy. Or even if you got your sex chromosome and there's a missing chromosome, it's still an aneuploidy, but it's called a monosome. You can also have problems on your chromosomes, which are structural. You might have translocation, you might have deletions, you might have inversions. These are called structural problems of your chromosome. So today, I'm only dealing with a problem with numbers, which we call aneuploidy. And we are going to see what are they going to cause in a human being. So of the aneuploidy, I will decide to talk about Down syndrome because this is the commonest. It doesn't make sense to teach you about Patau, Edwards, which are rare. So Down is commonest, that's number one. Number two, these people, they live longer. I'm even seeing some here. So they live longer. We are living with them. So you can see the problem there. Once they don't die, they still be there in the streets. So they are mingling. So we need to take care of these people, right? Now, also another issue is to say, in about 33% of Downs, they don't show major abnormalities. So don't look around. They don't show major abnormalities, but as we can see them. Now, let's go ahead. So now I want to talk about something which we call soft markers. What do we mean by a soft marker, right? So if we say a soft marker, as we shall see, it's a minor deviation from normal. You can see even our noses, our eyes are a bit different, right? So something might be just a minor deviation from the normal, as we shall see. Let's go. Now, so if you find a marker, which we call a soft marker, right? It is found in an increased incidence in aneuploidy, and it's less in euploid fetuses like us. But do not constitute a structural defect. So what do we mean by that? Let me show you the next slide. So the presence of a marker increases the risk of a chromosomal abnormality, but does not confirm. And absence of a marker decreases the risk of a chromosomal abnormality, but does not rule out the abnormality. Now, these are the soft markers. So I mainly concentrated with the second trimester screening. Why? For a first trimester, it's straightforward, right? For a first trimester, it's straightforward. But for second trimester, when these patients come around 16, 18, 20 weeks, these are the soft markers which you are going also to check for, to make a diagnosis, to make a high risk for aneuploid. So you can see here when we are doing our scans, I don't know whether it's coming out clearly. So these ones, I know most of the people, they are afraid of images from our scan. So I just put a drawing there. So you can see, these are the structure we'll be looking for, the knuckle forward, cisterna magna, you name it. Right. Now, look at this picture now. If you can see there, we are talking of a nasal bone. That's how things appear on your scan. You can see the bottom picture there. And it's also important to say that with this soft marker, when you are trying to screen for Downs, you need also to have a reference chart. I think Prof. Nikolai try to put a reference chart because you can see our noses are quite different. Some they are high there, some they are flat, some they are. So you can see with the gestation, if you are Indian, you need to have these values so that you can compare that nose which you found to say, is it in the normal range for us to call it a soft marker or it's not a soft marker. You can see echogenic bowel. You can see the small whitish somewhere there. Let me move for the sake of time. All right. You can see an echogenic intracardiac focus there. It can be in one of the ventricles, can be in the atria. It doesn't matter, so long as you see an echogenic intracardiac focus. The newer studies are showing also, you can see on the left side there, your nice brachiocephalic branching, but also you can also note that in babies with Downs, there's a risk that they might have an aberrant right subclavian artery. This is anatomy. I think you've been taught by Dr. Simon, is still there. He knows this anatomy quite well. Now, we move on. That's the diagrammatic representation of the aberrant right subclavian artery. Let's go. So now this study was also published where they also noted that the isolation of this aberrant right subclavian does not seem to be associated with significant risk. I know there were some publications. I'll come back to it in the next slide. Right, so this one you're talking of mild ventriculomegaly. All these pictures I'm just showing you so that when you do your scans, you also check for these features in your fetuses to say, are they at risk since they will be coming in the second trimester. So that's a mild hydronephrosis. Maybe I might put it as an MCQ for the MMed to say, mild hydronephrosis, is it a soft marker? So you might get it wrong if you don't get this slide, right? Then you talk of coronary plexus. You can see on the diagram there, these are the coronary plexus cysts. If you see them, you know that it's a soft marker. All right, you might find also a single umbilical artery, like in this case, it's also a soft marker. Or a mega cisterna magna, like there, that's how it appears as I've been showing you. It's also a soft marker. And these are other soft markers. Now, then what if you note all those soft markers in your baby? So you now come to your table now. I need you to concentrate because this is the difficult part of the slide. So you've noted your soft markers. You also have these charts there. So if you find, let's say, an intracardiac echogenic foci, like I said, so your likelihood ratio will be 5.83, right? So if you go now to the calculation, so you would say, if you find an intracardiac focus, the positive likelihood ratio is 5.3. But maybe you didn't find ventriculomegaly, you didn't find Knackout Ford, you didn't find echogenic bowel or mild hydronephrosis. Simple maths now. So you multiply your likelihood ratio with the negatives of these, which you didn't find. So you can see there, 0.94 is this one, times 0.84 is there, times 0.9, just punch in your calculator, all these negative likelihood ratio, then you get 0.16, right? So then you would say 5.83 times the negatives of these things which you didn't find when you did the scan. Is it clear? Good. I hope you are not bunking maths lectures at A-level. Right. So after that, we know that every woman who is coming, we had an a priori risk. What do we mean by that? Even before touching a woman, she already have a risk for Downs, which will depend on the age, right? We know the ages. you get a risk for that. Then you calculate your likely ratio, then you punch in, then you identify your patients who need an invasive test. Is it clear at this point? It's clear. All we are doing with all these arithmetics and everything, we are just trying to find a small group of people who are at risk of having a baby with aneuploidy. It's not a diagnosis. A screen test is not a diagnostic test, which means after you screen and you find that maybe just a small population is at risk, then you are going to do a diagnostic test. Well, the diagnostic test is quite invasive. It's pointless to say you got 100 women like you are in here, then you just go for a diagnostic test. It means you are going to get a jab to 100 women, which are unnecessary risk, miscarriages, and all sorts of things which are associated with an invasive test. So what we are doing is just getting those who are at risk, then we are going to send them for an invasive test. Right. So these are some of the biochemical markers. I've shown you the ultrasound scan features. Then these are the biochemical which you are going to track. So we used to talk of the triple test, the quadruple test, but now they are also talking of a penta screen where you are doing 5 of them on a patient, right? So if they afford, you can go for biochemical markers after your scan. But if they don't afford, you just stick to your scan. Now, sorry, I don't want to take much of your time. So now we are almost close to the end. Some might ask us to say, what about those patients who had a first trimester screening and now they are coming in the second trimester? Should we continue to screen them? So we are now talking of an integrated screening strategy, whereby even if you've been screened in the first trimester, you still go for your second trimester screening, where we can do a quadruple. So with this one now, we are saying if you got in the first trimester, you've been screened, you still go on and do your second trimester screening, then you get an integrated test. You combine the first and the second. And some are even talking of a stepwise screening to say for those who were at high risk in the first trimester, you can subject them to screen, and those who are low, you don't need to screen them the second trimester. Okay, so this is the stepwise, right? To say that if you had done a screening the first trimester, if you are high risk, you just go for an invasive test. If you are low risk, we still put you into a second trimester screening method. That's a stepwise. So this is the coordinate test. Again, we are saying that if you are high risk, you go straight. And if you are in the intermediate, you go for your second trimester screening. And if you are low risk, there's no need. So it's just a way of doing things. Okay, so I think this is my last slide. So our take-home message here, what are we saying? We are saying every pregnant woman should be offered a screening test. If they come in the first trimester, if they are able to do a blood test, you can do a combined test where you combine your scan as well as a blood test. Even if they come in the second trimester, you still screen them. If they had a screening test in the first trimester, you can still screen again in the second trimester. So every pregnant woman should be offered this screening test, right? And I've already alluded to say the risk assessment, you combine your biochemical as well as your scan. Then we also noted that soft markers, they are independent markers of aneuploidy. But be careful with these soft markers. Don't be overzealous if you find a soft marker, because it might be just a variant of the normal. So you'll be shocked when the baby is born without Down syndrome. Yet you will 100% say, I think Down, I've seen an echogenic choker. So you need to put up into the mathematics. So, and we also say that detection of NMARK should prompt a detailed ultrasound scan. So we're showing you those soft markers so that if you note any of those soft markers, please send these babies for a detailed ultrasound scan, be it in private or at government hospital. And we also noted that in low-risk pregnant women, most of the markers do not significantly alter the aneuploidy risk. That's self-explanatory. And also we noted that with NIP testing, the isolation between isolated soft marker and aneuploidy risk is not relevant. So I think the take-home message is very clear now to say let's screen our patients in the first trimester, even the second trimester, and you can also do your integrated test where you do the first and the second, or you can do it in a stepwise management. Because you have seen that sometimes it's to do with affordability. Some might not afford the NIPT, so you can stick to your scan findings. Some who afford, you can still add your soft marker. And also you need to cancel your patients. I know most doctors are not good at canceling the patient, because you find the patient coming to say, I've been offered a screening test, only to find that was the nuclear transfusion. Just be clear to say this test is not 100% for Downs. We need to add some biochemical markers so that at least they come with a clear vision. Thank you.